Hello, this is Dr. Jenkins. Here we are for your video on finishing the skeletal system, and then I want to start the joints. All right, so in lecture, we finished last talking about the scaphoid bone. So if you remember, we were talking about how bones almost always have a very good blood supply, but I give you an example of one bone that doesn't. There's a bone in your wrist called the scaphoid, and when it's fractured, it commonly tears a little branch off the radial artery and therefore cuts off the blood supply. So if this bone is fractured, which can happen if you fall on an outstretched hand, if you're falling and you put your hand out to soften the fall, this doesn't heal very well. So more time is needed, more immobilization. It can heal, it just takes longer. And I don't think I showed you this, but here we can see the outline of the scaphoid bone on an MRI, and clearly there's a little crack right across there. Not the bone you want to fracture. All right, so let's pick up where we left off, and all that's left here would be the lower extremity. Remember, in lab is when you just need to memorize the names of the bone. So in lab, memorizing names of bone. Here in lecture, we're talking about function. So here we go. Just like the shoulder girdle, there is a pelvic girdle, and the function is very similar. The function of the shoulder girdle was to attach the arm to the body. The bones that make up the pelvic girdle function to attach the legs to the body. Attaches the legs to the body. This also helps to support weight. But really, the primary function for both that I want you to know is both the pectoral or shoulder girdle and the pelvic girdle are the bones that attach the attach the arm to the upper body. The pectoral or shoulder girdle are the bones where the arm attaches to the body, and the pelvic girdle are the bones where the leg is attached to the body. Not surprisingly, this includes the pelvis and sacrum and coccyx. Attaches leg to the body. Now, we went through this in a lab, so for lab, you need to know all of this. We talked about the 3 regions of the pelvis. But what I want to do here is I want to remind you of the socket. So here we're talking about function. If you remember the function in the shoulder, the glenoid cavity has a shallow socket. So it's not very strong, but the shoulder has a shallow socket to allow for more movement. As I mentioned in lab, the acetabulum, which is the socket for the hip joint, is very deep. So this is all about the acetabulum is the socket that the head of the femur is going to attach to. This is all about a deep socket for strength because it's supporting more weight. And we have less mobility, but that's okay because its primary function is to support weight. I also want to talk a little bit about some of the differences in the pelvis between the male and the female. Now, you don't need to know all of this. That would be insane. But you probably already know this. This is an area of the skeletal anatomy where there are differences between the biological sexes. So, not sure if you can tell, but I think you should be able to. Here on the right is the male skull. Here on our left is the female. So what are some of the major differences? The opening of the female skull is wider. So for the female pelvis, opening is wider. Of course, all these adaptations for the female are all about childbirth, whereas in males, the opening is narrower but more up and down. Something else I want to point out that you can see really well from these pictures, I like these pictures for that reason. Look at the angle of the sacrum and the coccyx. In the male pelvis, that sacrum and coccyx curve pretty far to the back. So that tip of the coccyx comes pretty far here. But in the female, it is not curved as much. Less curvature of sacrum and coccyx. It's all about, for the female, leaving the most possible space for the baby to come out. It doesn't matter that in males that sacrum and coccyx comes back a little bit more because they don't need to pass a baby through. The structure of the male is all about support and strength. So for women, these adaptations are for childbearing, of course, and for men, it's more about support and strength. You only need to know what we're covering. I give you some other examples because there's many, many differences, but you only need to know the ones that I just talked about. All right, moving down, we talked about the femur. Let's see what I have here. We talked about the head. So I would like you to remind yourselves of the bones and bony structures that form joints. So the hip joint is formed by the head of the femur into the acetabulum of the pelvis. Everything else here is for a lab. I'd like you to remember that the tibia is the medial bone. It's larger and therefore plays a role in weight bearing. You can see some extra information. The tibia and the fibula are connected by this interosseous membrane. It's connective tissue. The fibula, I'm going to come back to that. The fibula is the smaller one, and as such, it's not so much about weight bearing. It's more about attachment site for muscles and ligaments. I skipped over this. You don't need to know this. Maybe you're familiar with it. It won't be on your test. There's a condition called Osgood-Schlatter's disease where there's a abnormal raising of the tibial tuberosity. You may remember from lab, and you do need to know it for lab. The bump right below the knee on the tibia is called the tibial tuberosity. This is where the quadriceps muscles attach. It's normal to have somewhat of a bump there, but when that bump becomes exaggerated, it shouldn't be quite that much. And look at this x-ray. You can see a crack here. So part of the tibial tuberosity is being pulled up. This is a condition that happens in adolescence, during puberty, when the muscles grow faster than the bones. So the quadriceps are the muscle group up here, and the quads attach there. So what can happen, sometimes the rate of growth is not quite even. So if the quads, the muscle, grows faster than the bone, the quads are growing, getting stronger, and therefore every time the quads contract, it has a force in this direction. And sometimes the tibial tuberosity can't handle it. This will not be on the test. Maybe you've heard of it. There's not really that much treatment aside from time once the bones grow and catch up, but won't be on the test. All right, you already remember that the foot is made up of the tarsals, metatarsals, and phalanges. Nothing new there I want to add for lecture. However, I do want to talk a little bit about the arches. Let's talk a little bit about the arches. If we look, if I go back for a moment, everyone knows this, but have you ever wondered why? Let's see here. So the bones of your foot are purposely built so there's a big arch there from both the medial and the lateral view. So the bony structure is high like that. And underneath that, we have connective tissue. You don't need to know the names of the arches. But what we have are thick bands of connective tissue called our arches. Some people naturally have a higher arch. But you have the bones, and then those bones are held up by a thick sheath of connective tissue called the arch. You actually have 3 of them. 2 of them that run the length of the foot. And then as you can see here in red, one of them runs the opposite way. So we should have somewhat of an arch, meaning that these connective tissues are strong enough to hold up the foot. So you don't need to know the names of the specific arches, but I do want to talk about why. So we have these arches, and these arches have 2 functions. One function is for, let's see how I want to say it. Let's say shock absorption. I was going to say weight distribution, but I think shock absorption is a better way of saying it. Think about our feet. This is the contact point with the ground, right? We are bipedal organisms. We walk on 2 legs, not 4. So all of our body weight is slamming down with every step at this contact point. Having an arch, having these structures that are raised, and the connective tissue is a little bit flexible. We wouldn't want our bones to be just flat against the ground. Then it would just be like rocks, there's no shock absorption there. But by having this somewhat flexible connective tissue, when we're non-weight bearing, it does look like this, where there's space underneath, right? Or there should be. But what it means is when we land, the arches flatten out. And that's a way to absorb some of the shock. Really important. The second function is for a springing action. And what I mean when I say this is it gives us some propulsion. The shock absorption is the function that happens at heel strike or landing. That shock absorption is the function that occurs when you actually land or heel strike. The springing action or propulsion is what happens next when you toe off. So every time you heel strike and land on your foot, that arch comes down a little bit to act as a shock absorber. But then, in the very next instant, when you go to push off and take your next step, push off, that connective tissue, it was stretched, and now it recoils like a rubber band. We would not be able to be as forceful coming off our toes without that arch. Now, of course, I know everybody's going to ask this question. I might as well just answer it. Some people are more flat-footed. This is not going to be on your test, but if you wanted to know, a flat foot, that condition is called pes planus. An abnormally high arch is called pes cavus. You don't need to know these. So it's normal to have an arch. It could be abnormally high, pes cavus. It could be abnormally low, pes planus. Is it the end of the world? No. Everyone wants to think, oh my God, it's more common to have the flatter feet, pes planus. Yes, those with flat feet might be at risk for having more issues due to less shock absorption or less springing. But in practice, most of the time, we leave it alone. Most of the time, other parts of the leg, knee, hip, lower back, the body compensates. So I know sometimes you can look at someone, maybe even yourself, and you can look, oh my God, my arch is so flat. Well, in most instances, the rest of the body has adapted a little, and it's not a big deal. So sometimes there's a tendency to throw an arch support in there, but if there's no pain, I would just leave it as it is, because once you alter the foot here, there are up chain effects. Everything is a kinetic chain. So how you land on your foot, those forces are transmitted up to your ankle, up to your knee, up to your hip. So if you alter your foot mechanics, you could actually create more problems, because then you could be throwing off the ankle, knee, hip, even the lower back. So if there's no pain, usually we just let it be. Okay, that's it for this chapter. I do want to start joints. So let's start joints, and then we'll finish the joints in our next meeting before we have our next lecture exam. So we just finished the bones, so it therefore makes sense to have a chapter on joints. So what I want to do in the rest of this video is just set the scene. I want to define joints, talk about the types of joints and what motions are possible, and then talk about some specific types of synovial joints. And then we'll finish up the rest when I see you in person next. Okay, as always, you need to know only what I'm pointing out. So make sure you can define joint. A joint is where two or more bones meet. The fancy word for a joint is articulation. So those two terms are interchangeable, joint or articulation. Where two or more bones meet or connect. Of course, the functions are mobility, and it keeps the skeleton together, so it holds things together, and it allows us to move. This whole system wouldn't work if we just had bones and they didn't connect. Wouldn't make any sense. What's nice about these articulations or joints is that they're usually named for the bones they connect, which makes it really logical and straightforward for a change. Tibiofemoral, that's your knee joint. Humeroulnar, that's your elbow. Glenohumeral, that's your shoulder. So they're named for the bones they connect. What a lovely thing. There are two ways that we tend to classify joints. It's possible to classify them by function. However, what I'm going to ask you to know are the classifications by structure. When you go on to other classes, you might have to know them by function. But for this class, we're going to do it by structure. So the three types of joints that you need to know are fibrous, cartilaginous, and synovial. All right, now before we do that, here are the classifications by function if you want, but for me, you don't need to know these. We're going to do it classification by structure. So the first one you need to know, this is very straightforward, a fibrous joint. This is where bones are joined by connective tissue, and they are immovable. An example would be the sutures of the skull: coronal suture, sagittal suture, squamosal suture, lambdoidal suture. It's still a joint because it's where two bones meet, but in this case, they are immovable. So for each of the types of joints, you need to know their basic definition. So here, fibrous joints are when bones are joined by connective tissue. You need to know what type of motions are possible. Here, none. And then be able to give an example. So here, the example we're going to use would be the sutures of the skull. Very straightforward. Then we have a cartilaginous joint. As the name suggests, this is when two bones are joined by cartilage. It gives us limited movement. I would say it gives a little bit of flexibility. An example we can talk about would be the pubic symphysis. That's on your list for lab, where the two pubic bones come together in the front, and the joint between the ribs and the sternum. Sternocostal. These are both examples where bones are connected with cartilage in the middle. It gives us a little bit of movement or flexibility, but not like flexion or extension, nothing like that. Just a little bit of give. In the case of the ribs, every time we breathe, we want the rib cage to expand a little. So it is the type of joint here with the cartilage in between that allows the ribs to expand just a little. In the case of the pubic symphysis, it's more about shock absorption and a little bit of movement or flexibility. But by and large, the most common type of joint, and the joint that you probably think of, is the synovial joint. These are fluid-filled joints. They permit the most movement. This is where we talk about flexion, extension, abduction, adduction, internal, external rotation. These are the limb joints that you think of: shoulder, elbow, wrist, hip, knee, ankle. Synovial, synovial, synovial. Fluid-filled, and they allow for the most motion. Now, we are going to talk a little bit more about the synovial joints. Pardon me. Synovial joints have added features. We didn't have to have this discussion with fibrous joints or cartilaginous joints, but we do when it comes to synovial. So here are the added structures that are present in every synovial joint. It doesn't matter if it's the knee and the shoulder, or if it's an interphalangeal joint, which is a joint between the different bones of your fingers. Even the smallest synovial joints have all of these things. Okay, we already talked about the fact that synovial joints are filled with fluid. To hold that fluid in, we have a joint cavity. Here, it's called, hold on. I'm ahead of myself. I meant to say joint capsule. Joint capsule. So we have fluid. In this picture, the fluid would be floating in the middle of the joint, right? Synovial fluid. Because we have fluid, we have to hold that fluid in. How are we going to hold that fluid in? Here it's called articular capsule. Usually we say joint capsule. A joint capsule is a connective tissue covering. We talked about it in the tissue chapter. It is dense, irregular connective tissue, but it's it's connective tissue that surrounds the joint. Connective tissue that surrounds the joint. What it does, holds the fluid in. We have to have something to hold the fluid in. Otherwise, the fluid would just drain out. So in this picture, this here is the joint capsule. An analogy that I like to think of is like saran wrap. Imagine we have this joint where two bones come together, and we have this connective tissue covering like saran wrap. It goes all the way around. It's like a thick saran wrap. It holds the fluid in. Now, when you dislocate a joint, then this joint capsule, this connective tissue covering, is going to be interrupted. And the problem with that is the joint capsule is not necessarily elastic. It doesn't, if it gets stretched, it doesn't recoil back to its original tightness. The fact that we have this joint capsule means that there's a cavity in between. So the cavity is the open space that holds the fluid. Open space that holds fluid. Sometimes it might be necessary for a doctor to shove a needle into the joint to drain fluid if there's an accumulation. They would be inserting the needle into the joint cavity. All right, good. Now, we should remember, but you may not, at the end of every long bone is articular cartilage. What color can I pick that'll be different? Let's do orange. Articular cartilage, it's really hyaline cartilage. If you remember from the tissue chapter, and I know you were like, why do we have to know this? Because this tissue makes up all these important things in our body. Hyaline cartilage is a type of cartilage that we find that lines the end of every long bone. Orange probably isn't the best color for this. In the picture before I drew on it, it's shown as blue. Hyaline cartilage. It's like a glove. It's like a little coating at the end of every long bone. Hyaline cartilage. You can say either hyaline or articular cartilage. It might be named articular because it's found at the articulation where the bones come together. It's like a little glove cushioning. Now, some joints have added cartilage, like the knee has a meniscus. The hip and shoulder have a labrum, but that's added cartilage. No matter where the synovial joint is, if there's added cartilage or not, we're always going to first and foremost have this hyaline cartilage, like a little glove that lines the end of the long bones. You don't want bone on bone, so a little bit of cartilage. And then lastly, on the outermost part, we have ligaments. I'll use pink. So I've tried to go from the deepest to the most superficial. Every synovial joint has a saran wrap-like covering called the joint capsule. It's a connective tissue that encapsulates the joint capsule. It's like a saran wrap covering, holds the fluid in. That fluid, of course, inside is called synovial fluid. The synovial fluid is housed in an open space called the joint cavity. At the end of every long bone is a thin layer of hyaline cartilage. And then further out, more superficial from the joint capsule, are reinforcing ligaments. We talked about some of these in the knee and the elbow. Every synovial joint has reinforcing ligaments. Ligaments connect bone to bone. Just having the two bone edges together is not going to be stable enough, especially considering all the stress that we put on these joints. So these surrounding ligaments add more strength, hold everything together. Okay, excellent. I mentioned this before. Sometimes we can shove a needle in there if we need to drain, if there's excess fluid into the synovial cavity. That synovial fluid, it's a little bit thicker. It's a little bit thicker than water. So I have molasses here. That's a little bit overkill. Can I say it's a little thick? Not quite like molasses, but a little thick. A little. And the functions, I would like you to know the functions of this synovial fluid. Well, first and foremost, lubrication. These are freely moving synovial joints. We got working parts moving all the time. We need something to lubricate, just like oil is needed for a car engine, moving parts. A little bit of shock absorption, and it does have some nutrients. So make sure you review all of the functions. Sometimes we have other structures. I've talked about ligaments. So every synovial joint has ligaments. I just wanted to make sure that you can define a ligament. Very important. After you leave this class with me, I would be very disappointed if we couldn't define tendon or ligament, especially for what you are all going for, right? So really important. Come on. I want you to leave here, and I want people to know that I'm doing a good job. Yeah. So a ligament connects bone to bone. And then, of course, surrounding every joint are also going to be muscles. And every muscle is attached to a bone through a tendon. So make sure that you can define tendon and ligament. Tendon connects a muscle to a bone. Ligaments connect bone to bone. I already told you that, we reviewed, in some synovial joints, we have added cartilage, like a meniscus or a labrum. But we're going to talk about that more later. Just for fun, here's a picture of a meniscus that's been taken out. That's a big chunk of meniscus to take out. 20 years ago, they would do more meniscectomies, take out the meniscus. Now, not surprisingly, they try and keep what they can because it's shock absorption. The problem is meniscus doesn't heal very well at all. This piece of meniscus, those white arrows, are pointing to what's called a bucket handle tear. Do you see this tear right in the middle? So that's where you want to look. Let me erase it. That little tear. Okay. So now that we've identified these, I'd like you to be able to look at an image. Here's an MRI. This is the knee. There's a lot that you should be able to identify. You should be able to identify the femur. I'm not going to ask you to do this on a test, but it's just another way to practice. Here's the tibia, and here's the fibula. We haven't gotten to muscles yet, but we will soon. So up here are the hamstrings. Down here is your calf muscle, known as the gastrocnemius. And then your quads are going to be up here. Here is the quad tendon going over the patella. Here's the patella. And the quad tendon continues all the way down, and the quadricep tendon will attach on the tibial tuberosity. We can see the joint cavity, open space. We can see the hyaline cartilage. Do you see this outline? Kind of looks like a glove. That's an outline of the hyaline cartilage. I know, it's on both. It's on the tibia too. Nice, beautiful cushioning. Good stuff, right? There's other structures. I'd love to talk more about it, but we can't. We gotta move on. Cool. Some other pictures, now we do a lot of a lot of arthroscopic things. We can shove a camera. This is what a normal knee joint should look like. Femur, tibia. This is the extra cartilage known as the meniscus. So what happened is here there was a torn meniscus. Frayed like no one's business. So what they did is they went in and they just shaved off that torn part. So maybe this isn't quite a normal meniscus, because if it was normal, these edges would be completely smooth, but they're a little jagged, because what they did is from this torn meniscus, they shaved off the edges. You don't need to know about a tendon sheath, but I would like you to know, also in and around synovial joints, we often have bursa. Bursae is plural. Individual would be bursa. A bursa is a fluid-filled sac. A bursa is a fluid-filled sac. You don't need to know the tendon sheath. This is a picture of the shoulder. You don't need to know the specific names of the bursa. But I like this picture because it clearly shows us some bursa. It's outlined in green. This is the subacromial bursa. Bursa are these fluid-filled sacs, for lack of a better word. So fluid-filled sac. They occur in areas where there's a potential for bone on bone. When we abduct our shoulder, it's very possible that the head of the humerus will butt up against the acromion process of the scapula. So because this is an area where we have bone-on-bone potential, your body has made a cushion, bursa. It's a fluid-filled sac. It's like a little jellyfish kind of thing, a little bit more firm than a jellyfish. Maybe you've heard of bursitis. These can become inflamed. So with repetitive motion, bone on bone on bone on bone, the bursa will fill with more fluid as a protection. But of course, it filling with more fluid can lead to irritation, bursitis. So just be able to define bursa. Here's a fun picture if you want to look at it. All right. So I want to continue talking about stability, and then I want to talk about the types of synovial joints, and then we'll pick up the rest for later. The stability of joints can be defined by a lot of things. This is nothing new though, okay? You don't have to learn anything more from this right now. What I want to remind you of would be our discussion of the shoulder versus the hip. The hip had a deep socket, so it gets its strength from articular surfaces. The hip has a deep socket, and it gets its strength from bones, from the bony structure, or articular surfaces. That's just a fancier way of saying it. The hip is a deep socket, gets its strength from the bony structures or articular surfaces. The shoulder has a shallow socket. It has a very poor bony structure. The benefit, though, is more movement. I'm going to talk about these other two later, so don't worry about those yet. We're going to come back to those. Just review: the hip, deep socket, gets its strength from bones or articular surfaces. Shoulder is a shallow socket, has very poor bony congruency, articular surfaces. But there's a reason why the shoulder has a poor bony structure. It gives us more motion. This is the same thing I've been saying, right? The shoulder, shallow socket, poor bony structure, less strength but more mobility. The hip has a very deep socket, stronger bony structure, more stability, but less motion. Okay, here's what I want to end with on this video: the types of synovial joints. Let's just make sure that we're still understanding what we talked about so far. We talked about the overall 3 types of joints. And I'm gonna have you know them by structure. There are fibrous joints. Fibrous joints are when bones are connected by connective tissue, no movement. Example is sutures of the skull. We then said there are cartilaginous joints, when 2 bones come together with cartilage in the middle. A little flexibility, but no real movement. A little flexibility. We gave 2 examples: the pubic symphysis and where the ribs attach to the sternum. And then, of course, the most common type of joint is a synovial joint. It's a fluid-filled joint, gives freely moving, flexion, extension, abduction, adduction, internal, external rotation, etc. And all of the limb joints are synovial joints. Now we're looking only at synovial. Now we're going to look at types of synovial joints. So underneath the category of synovial, there's actually specific types of synovial joints. I'd like you to know ball and socket, hinge, pivot, and condyloid, the ones that are starred. So these are all going to be fluid-filled joints with synovial fluid, a joint capsule, hyaline cartilage lining the ends of the bones, surrounding ligaments. They all have that. Folks, these are named by their structure, a ball and socket. It's when a synovial joint is formed with one end of the bone looks like a ball, the other end of the bone looks like a socket, hip and shoulder. This allows the most movement. We can do everything. We can do flexion, extension. We can do abduction and adduction. Aren't you glad that you memorized these before? They're coming back. And we can do both internal rotation and external rotation. Be able to know how the bones are connected, a ball into a socket. Be able to give examples, hip and shoulder. And you should know what motions are possible. All of them. Flexion, extension, abduction, adduction, and rotation. A hinge joint. It's just like it sounds, like a door hinge. An example of this would be the elbow. It's like a door hinge, right? A door can open or close, and that's it. So all that's possible here is flexion and extension, nothing else. Like a door can only open and close. A true hinge joint can only do flexion and extension, the elbow. Now, as an aside, the knee is actually a modified hinge joint. We're going to talk about this later in this chapter. Modified hinge joint. It's not a true hinge. The example I'd like you to know for a true hinge joint is the elbow. The example I'd like you to know for a true hinge joint is the elbow, flexion, extension. When we get to the knee a little bit later, you're going to remember that the knee is a modified hinge joint, and we'll talk about why a little bit later. You don't need to know a saddle joint, but I would like you to know a pivot joint. A pivot joint is something that allows only for a pivoting motion. Where this is found in the body is the proximal radio-ulnar joint. This is where the radius connects to the ulna. I asked you to know the ligament, right? The ligament that holds this together, we talked about it. The annular ligament. But this is the type of joint that allows only pivot. When we pronate or supinate, when we twist our forearm, it's the radius pivoting over the ulna. Do you see how these synovial joints are built based on their function, right? In this location of the body is only pivoting that's needed. Therefore, they arrange the bones so pivoting is easily allowed. You don't need to know, did I have plane joints circled? No. Last one I'm going to have you know is condyloid. I'm just picking some. Here we go. Last one I'd like you to know is a condyloid. When I think of a condyloid, it's really like a mini ball and socket. It's not like a ball and socket where there's a deeper socket and a very round head. It's kind of like a mini ball and socket where one end is convex, fitting into another end that's concave. So in that way, it's like a mini ball and socket. It can do almost everything that a true ball and socket can do. Flexion, extension, abduction, adduction. Circumduction is when you combine all the motions together to move a joint in a circular motion. I think of circumduction as a third base coach in baseball. If someone's rounding third base, if a runner is rounding third base to head home, the third base coach might be moving their whole shoulder in a circle to round them home. That's circumduction. An example of this is our MCP joint. This is your knuckle, but you're not going to say knuckles because the real name is metacarpophalangeal. Remember we said that joints are named for the bones they connect. Metacarpophalangeal, joint between the metacarpals and the phalanges. It's your knuckle if you could look down at your hand now, metacarpal, phalangeal, where the metacarpals meet your phalanges. MCP, metacarpophalangeal. All right, excellent. So let's end there. We will pick this up when I see you next. Study hard, everybody. Any questions, as always, let me know.